Hey everybody, this is Kevin Bass from thedietwars.com, and I want to talk about a paper, an article that is making the rounds in the diet and nutrition space on the internet. It's called Statins Are Associated with a 38% Increased Risk of Diabetes. And this video, the goal of this video is to ask the question, so what? So what? What does it matter that statins are associated with 38% increased risk of diabetes? Now this may sound weird to you. Oh, of course you want to be concerned with diabetes. If statins are causing diabetes, then that's bad because diabetes causes heart attacks. It causes microvascular complications like with the eyes, you loss of vision. It causes like gangrene, amputation eventually. If statins cause diabetes, shouldn't we not take statins? No. The point of this video is to say that this increase in risk of diabetes is not clinically important compared to the benefits of statins. Why? Because diabetes, the risk of diabetes increase is more than counterbalanced by the reduction in these same patients who are at risk of diabetes, who are getting diabetes, even among people with diabetes. The worsening of blood glucose in people who have diabetes, despite all of that, statins still make the things that we're worried about from diabetes better. So we worry about, the reason diabetes is so terrible is it causes, as I said, like loss of vision, like gangrene, amputation, heart attacks, cardiovascular disease. It makes all that stuff either doesn't make it worse or it makes it better, despite making the blood sugar levels worse. Why? Because the improvement in lipids, the improvement in LDL cholesterol causes a bigger positive effect on heart disease risk than the small increases in blood glucose levels. So there's like a 50% reduction in LDL cholesterol, while there's a tiny increase in blood glucose levels. But let's get to even some more important points here. This is a 38% increase in the risk of type 2 diabetes, but that's in an observational study. The people at baseline in this study, before they started the statins, had a higher risk of diabetes in the first place because they're not an at-risk population. So because they are an at-risk population, of course they have a greater risk of having diabetes. They had a greater risk of diabetes before they started the drug, just because of what they were, a more at-risk population. So yeah, they had a higher rate of new diabetes diagnosis. If you go to the actual trial evidence itself, and you look at the increased risk of diabetes in patients who are given a statins, you compare placebo rate of diabetes to statins rate of diabetes. So you give two groups the drug, you give two groups of treatment. In one group, you're giving a placebo or a sugar pill. One group, you're giving the statins. You compare the rate of diabetes in each of these groups. In the group given the sugar pill, 2.2% of people get diabetes. That's just because people naturally are going to get diabetes, right? In any given clinical trial, especially people who are not healthy, right? 2.2% got diabetes. 2.7% of the statin treated group got diabetes. That's 2.2% naturally, just from a sugar pill. It's not from sugar. It's not actually a sugar pill. It's not a sugar pill. It's like just a random pill. Could contain chalk. It's an inert pill. It's Doesn't have any effect. 2.7% in the statin-treated group. It's a 0.5% increase. 0.5% increase. That's far less than a 38% relative risk increase. It's like a 20% relative risk increase. Why? Because when you randomize the drug, and you're not just giving it to people who are unhealthy, but everybody's getting it randomly. Some people are unhealthy, some people are healthy. It's randomly given. And then you randomize the placebo. Some people are healthy, some people are unhealthy. You reduce these effects in these observational studies because only unhealthy people were given the drug in these observational studies, if that makes sense. More or less. It's a little bit of an over-explanation, or oversimplification, but that's basically the idea. Unhealthier people were giving it in the observational studies, so you're going to see more increased risk. So the actual increased risk is substantially smaller. It's like 20% increased risk. And that's on the backdrop of about 2.2% risk. So it's like a 0.5% absolute increase risk. It's very small. Nonetheless, there is an increase, okay? Maybe, according to this meta-analysis. And this is published by Feingold et al. It's called What Proportion of Symptomatic Side Effects in Patients Taking Statins Are Genuinely Caused by the Drug? Systematic Review of Randomized Placebo-Controlled Trials to Aid Individual Choice. And the conclusion was only about 1 in 5 new cases of people on statins were actually caused by the statins, because as we pointed out, people on sugar pill get it. So in this case, only about 18% of the additional cases in the people who were given statins are actually caused by the statins themselves. Okay. Another study found something similar. It's called Statin Use and Risk of Developing Diabetes Network Meta-Analysis. It's by Thacker. It's published in the Pharmacoepidemiology and Drug Safety Journal. And they found something like a overall 12% increased risk of diabetes, okay? If you look at all the randomized controlled trials, all the different drugs. And in some drugs, some statins, pitavastatin actually reduces the risk of diabetes because it reduces blood sugar levels, okay? Okay. This study showed something similar. It's actually much more recent. It includes more participants in newer studies. This is published in 2021, so 5 years newer. And it showed no increased risk of diabetes from these drugs. Now, rosuvastatin was associated with an increased risk of diabetes, and sometimes some higher intensity statin therapies are associated with risk of diabetes. Pitavastatin was associated again with a reduced risk of diabetes, but rosuvastatin showed a small increased risk of diabetes in this study, 14%. But overall, if you look at all the statins, it's no increased risk of diabetes, okay? So some studies show no increased risk. Okay, but there was a study called Jupiter. Published in the Lancet in 2012. It was called, this is not the study name of Jupiter, but this is another analysis of that data. This paper is called Cardiovascular Benefits and Diabetes Risks of Statins, Statin Therapy in Primary Prevention. It's by Ridker et al. Published in the Lancet, one of the top 2 British medical journals. And Jupiter was a 17,000 person study. They found among the people who are at higher risk for diabetes, they're at higher risk for diabetes, so they're already at high risk at baseline. A statin allocation was associated with a 38% reduction in primary endpoint, that is to say, heart attack, stroke, hospitalization for unstable angina, arterial revascularization or cardiovascular death, 39% decreased risk, 36% decrease in risk in venous thromboembolism, and a 17% reduction in total mortality, okay? And a 28% risk in increased risk in diabetes. Okay. If you have a high rate, and actually we're just gonna open this paper up. We're gonna open this bad boy up because I'm in that mood. We're gonna get this guy in. I probably do that with every paper. Mario's always in that mood. But like, let's look at the actual figures here because this is important. That's an interesting figure. This is perfect. Oh, this is perfect. I haven't seen this figure before, so it's an unbiased assessment. I'm not just selectively picking this, I'm showing you what the figure shows. So look, among people with one or more major diabetes risk factor, right? Let's get the PDF, because the PDF is going to look better for us. Yes, it's a beautiful PDF. Great. Among people with one or more major diabetes risk factors, I've not seen this figure before. I'm going to read it off and then report it. For the primary endpoint, again, a really large reduction in those primary endpoints. So like the death, heart attack, stroke, venous thromboembolism, and all-cause mortality is a really large reduction in those events for those given rosuvastatin versus placebo. Among those given rosuvastatin, there's only 96 people who had any of those events, and among people with placebo, 157. It's like 50% more. More than 50% more. So that's interesting. Among any death at all, there is a 33% reduction in any death at all. Okay? Is that all-cause mortality? It's cardiovascular death. It's cardiovascular death. It's not. Let's check. No. This is all-cause mortality. This is all-cause mortality. The primary endpoint was cardiovascular death, but there's also an all-cause mortality reduction. So in the placebo group, people who had diabetes risk factors, 262 people died. And in the rosuvastatin group, 175 people died. So almost 100 fewer people that died because of rosuvastatin out of 262. That's crazy. It's crazy. It's a lot of fewer deaths. Oh, no. Sorry, that's primary endpoint plus any death. Yes, primary endpoint plus any death. Okay, so yes, all primary endpoints plus any death. No, but the number of reduced deaths was still substantial. It was still almost 20% reduced deaths. So it's from 132 to 109. Okay? All right. Let's look, though, at diabetes risk, right? So in the placebo group, 204 people got the placebo treatment. 204 people got diabetes in the placebo group. And in rosuvastatin group, 258 people got diabetes. Okay? So there's about a 28% increased risk of diabetes among people with diabetes risk factors, right? Because if you increase your blood glucose levels, the more people who increase their blood glucose levels, the more people are going to slide over diagnostically into diabetes territory. Well, you can see that here. So among people who were at the border of having diabetes, once you gave them a statin, they would tend to increase their blood glucose. And across most groups, no matter how high your diabetes was at baseline, how high your blood glucose was at baseline, most people in most of the groups, there was on average an increased risk in diabetes in most groups. So it's probably just increasing blood sugar overall. And then as a result of that, there's going to be an increased risk of diabetes because you're just going to cross the diagnostic threshold. Okay. But if you compare that to the reduction in deaths and heart attacks, etc., which is the reason we're so concerned about diabetes, it's a no-brainer. It's a no-brainer. And there's one more paper we need to look at to really drive this point home. And when I looked into this further, I saw, for example, in the interpretation of the evidence for the efficacy and safety of statin therapy, that Lancet paper from 2016, I saw that there's no evidence whatsoever that statins increase the risk of microvascular complications. In fact, they're associated with a reduced risk of microvascular complications, and in randomized controlled trials, for example, it says in this paragraph, in randomized controlled trials, there is no increased risk of retinopathy. It says, in addition, there is no evidence of eye-related microvascular complications due to statin therapy. For example, despite careful assessment of more than 12,000 patients in Excel and in 4S, no adverse effects on visual acuity were detected. There's ongoing research. There's no evidence whatsoever that it causes increased risk in microvascular complications. If that evidence changes, I will be the first to report it. But to summarize, statins reduce the risk of macrovascular complications, including heart attack, stroke, venous thromboembolism, death from cardiovascular events, and overall death, all-cause mortality from all events in people who have a risk factor, at least one or more risk factors for diabetes. So in the very group in which you're worried about them getting worse outcomes, they're actually doing better. And even in diabetic patients, they're doing better as far as their risk of death, risk of cardiovascular events, etc. There's no evidence that it increases the risk of microvascular complications. So why are we worried about some isolated blood marker, blood glucose, when we should actually be worried about health outcomes? It's because people who are worried about this stuff, who worry about this isolated blood marker, they don't understand how the whole picture fits together. And ultimately, for diabetes, we're interested in what are the health outcomes as a result of diabetes. We're not interested in tracking some isolated blood glucose marker for its own sake. We're interested in that particular marker because it may be associated, or it is associated, and is associated at least causally to some degree with these bad outcomes. But if you reduce these bad outcomes, despite increases in this blood marker, we don't care. It doesn't matter. That's why it doesn't matter. Who cares? That's the point of this video. Like, who cares? It doesn't matter. There's no evidence it matters, and there's all the evidence in the world that statins will only help people who have a higher risk of diabetes, or even people who have diabetes who are worsening in their blood glucose. Now, it's fine and all good. It makes complete sense, 100% sense. If somebody is on a statin and they're seeing like a serious deterioration in their blood glucose, we want to be worried about that on an individual level because, okay, maybe that person doesn't respond very well. And so we could decrease the statin dose. We could decrease the statin dose and add ezetimibe or PCSK9 inhibitor, some other therapy that doesn't hurt the blood glucose. We can change to a new statin like pitavastatin instead of, say, rosuvastatin, if that's a problem. And in that case, we can keep getting the benefits of statin therapy and LDL lowering therapy without necessarily getting the downsides, which is to say worse blood glucose. And so for people who have this serious deterioration in their blood glucose, they can try something different and still get the good results. It doesn't have to be either or. We should use all the tools in our toolbox in order to help people. We shouldn't just like limit ourselves because we're like, oh my God, blood glucose is going up, therefore it's necessarily bad. It may not necessarily be bad. It may be a good thing despite blood glucose going up a little bit. And people need to understand that the overall balance of risk and benefits for statins are overwhelmingly in the direction of benefits, even in people with diabetes. Not even, especially in people with diabetes, because people with diabetes are at increased risk of heart attacks. And if you relatively lower the risk of heart attacks in those people, you're going to cause even a greater benefit in the absolute number of people who are not having heart attacks anymore. So the risk of statin therapy is even greater in people with diabetes or at risk for diabetes than people who are relatively healthy, such as myself. But that's why I take a statin despite that, because I don't get any side effects at all. I don't notice any side effects whatsoever. I've halved my LDL cholesterol, and I don't notice any side effects at all whatsoever. So why not run around with LDL cholesterol of 50% lower than it would have been? Seems like a great idea. Okay, cool. If you like this video, click the subscribe link. That'll be great. Click the subscribe link. Let me know what you think about it. Send a comment. You think I'm an idiot? You think I'm an idiot? I'll block you if you call me an idiot. But if you think I'm an idiot and you want to say so in a very evidence-based, scientific way, go ahead and do that too. More comments, the better. More feedback, the better. Subscribe to the podcast, The Kevin Bass Show. It's going to be Apple Podcasts and on Spotify. Leave a rating or review. That's fantastic as well. Check me out on TikTok, Instagram, Twitter at Kevin N. Bass, KVINNBASS. If you want to support the show, you can check me out at Patreon, Kevin N. Bass, KVINNBASS on Patreon. Do all that stuff. Let me know what you think about the show. Share. So if you find this stuff interesting and helpful, if you're finding some of the misinformation that you're seeing bad, take your time out to share this stuff. Share this stuff with your friends. Send it to your grandma. Send it to your cousin. Send it to other people that you know on Facebook. Share it on Facebook. Because this kind of stuff is important to know. So the wider circulation it gets, the better off people are going to be. Thanks for watching. Peace.